So good morning. Yeah, good morning classmates, morning ma'am. So today I will be presenting regarding the care of patients with acute gastroenteritis with moderate dehydration. For the demographic data, the patient is their MA, which is 75 years old and is married and was a messenger in his early days. And he's from Payapi, Dumaguete City, and he's a Roman Catholic, Filipino, of course. And then he was admitted on December 17, 2013 at 2:40 p.m. And he was under the care of Dr. Cesar Oligo. His chief complaints are LBM and then acute gastroenteritis with moderate dehydration. And history of present illness, 14 PTA, patient had onset of passage of loose, watery, non-mucoid, non-bloody, yellowish colored stool. About 1/4 to 1/2 cup in amount per episode associated with abdominal pain characterized as burning cramping at the hypogastric area, moderate to severe pain. The patient had a total of about 15 episodes since onset. He also claimed that last food intake was mangoes. He self-medicated with the following medications: loperamide, ranitidine, which offered some relief. Day of admission, symptoms persisted. He decided to seek admission. General impression: received client lying in the bed, sleeping in a seat position, with IVF C5LR 1 liter running at 33 drops per minute at the left metacarpal vein, with side drip of PNSS 50 plus 60 mg of potassium chloride at 25 cc per hour, all infusing well. Client's respirations were effortless and abdominal without the use of accessory muscles. So for the genogram, the client is verbalized that he's not familiar with his grandparents on both sides. So, kuan is a parents, and then his siblings, and then his child. So, as you can see, walay kanang his family history of the common diseases, with mga diabetes mellitus, hypertension, of asthma. So, and then also there are 10 of them, 10 ay 9, so 9 young siblings, and the only living na nakay siya, which is the youngest, and then their eldest, and then, okay, so, as you can see, walay familial diseases, except for his third sibling, which died of renal failure. So, developmental milestones. My client is 75 years old, so for late adulthood, so 65 years old to death, and then ego development outcome, integrity versus spare, and then for basic strengths is wisdom. So, the rate of a person's growth and development is highly individual. However, the sequence of growth and development is predictable. Another term used to describe the old or the extreme aged is frail elderly, although ang frail elderly, it is referred to as katong na mga older people who have kanang mga dementia, like this, and personal functional impairment, whatever the age is. People aging 65 years old and older belongs to the category of older adulthood. Various systems are used to categorize the aging population. So, young old, it is from age 65 to 74 years. Middle old, aging 75 to 84 years. So my patient is 75, so he belongs to the middle old. And then the old guys, 85 and older. Patient M is 75, so yeah, he belongs to middle old. So for the physiological development, there are normal physiological changes anticipated for older adults. These physiological changes are not pathological processes, but may render the older adults vulnerable to some common clinical conditions. Some experience all these changes and others experience only a few. The body changes continuously with age, but the effects on particular older adults depend on their health, their lifestyle during the younger days nila, and environmental conditions. Integumentary system. The skin loses resilience and moisture in the older adults. The epithelial layers layer thins and elastic collagen fibers will shrink and become rigid. Wrinkles on the face and neck reflect lifelong patterns of activity and facial expressions. The pull of gravity on tissue and diminished elasticity. Spots and lesions may also be present on the skin. So there may also be decreased perspiration due to the reduced number and functions of sweat glands and thinning and graying of scalp, pubic, and axillary hair due to the progressive loss of pigmented cells from their bulbs. Nail growth is slower and increased thickening with bridges due to increased calcium deposition. So my patient's skin appears slightly dry, smooth, and equal bilateral with slightly cooler sa iyahang lower extremities. Sagging and excessive wrinkling of skin were also noted on his face and the neck. His scalp hair is gray, thin, and fine. Nail beds are slightly pale with capillary refill within normal limits. For the neuromusculoskeletal system, with aging comes gradual reduction in the speed and power of skeletal of voluntary muscle contractions and sustained muscular effort. Exercise can strengthen weakened muscles, and up to about age 50, the skeletal muscles can increase in bulk and density. After that time, there is a steady decrease in muscle fibers, ultimately leading to the typical wasted appearance of a very old person, as we can see kanang usually if tigulang na kay mga diwang. Thus, elders often complain about their lack of strength and how quickly they tire. Activities can be carried out, but at a slower pace. Often, balance is impaired with age. So, vulnerable sila sa kanang mga falls. Prolonged muscle efforts may be sustained by older adults provided they take judicious rest pauses and avoid capacity or peak performance. Decrease in muscle tone is also evident in older adults as a result of diminished physical activity. Elders compensate for this reaction difference by being exceptionally cautious, for instance in their driving habits, which exasperates some impatient young drivers. Slight loss in overall stature occurs with age. This can be exaggerated by muscular weakness resulting in a stooping posture and kyphosis, osteoporosis, and pathologic fractures. Some degenerative joint changes occur, making movement stiffer and more restricted. This stiffness is aggravated by inactivity. So, patient M shows decreased speed and power of skeletal muscle contractions, which is common sa older adults. Slowed movements and slowed reaction time is also noted upon observation. He can ambulate, but it is made sure that someone is with them kay pasigma tumba niya. And then, for the next is sensory and perceptual. Each of the five senses becomes less efficient in older and adulthood. Changes in vision associated with aging include the obvious changes around the eyes, such as shrunken appearance of the eyes due to loss of orbital fat, the slowed blink reflex, and the looseness of eyelids, particularly the lower lid, due to the poorer muscle tone. The loss of hearing ability related to aging, called presbycusis, hearing loss is greater in the higher frequency than the lower frequency. Thus, the older adults with hearing loss usually hear speakers with low distinct voices best. So, older people have a poorer sense of taste and smell and are less stimulated by food than the young. It affects the appetite of the older adults, contributing to poor nutrition. Loss of skin receptors takes place gradually, producing an increased threshold for sensations of pain, touch, and temperature. The facial expression of the older adults is more pronounced from loss of subcutaneous fat and skin elasticity. Facial features may appear asymmetrical in skin because of the missing teeth or improperly fitting dentures. So, my patient manifested normal changes such as pronounced expression and diminished hearing acuity. Also, almost all teeth are missing, and he's wearing a denture sa iyahang K9 tooth. He likely experiences increased sensitivity to glare and decreased ability to adjust to darkness. So the next would be the thorax, lungs, or the pulmonary gland. So respiration efficiency is reduced with age. The person inhales a smaller volume of air because of the musculoskeletal changes in the chest wall that reduce the size of the chest. Mucus secretions tend to collect more readily in the respiratory tree. Thus, susceptibility to Respiratory infections increases in elders. Because of the changes in the musculoskeletal system, the configuration of the thorax sometimes changes. The anterior-posterior diameter of the thorax increases, vertebral changes due to the osteoporosis, leading to dorsal kyphosis, the curvature of the thoracic spine. Calcification of the costal cartilage can cause decreased mobility of the ribs. So, if decreased mobility sa ribs kay ang expansion ma-affected po. The chest wall gradually becomes stiffer. Lung expansion decreases. So, my patient has slightly increased anterior-posterior diameter, which is barely recognizable, with respiratory rate and pattern of 21 cycles per minute, shallow in depth, regular, and without the use of any accessory muscles. Crackles and wheezes are not evident upon auscultation. So the next would be the heart and vascular system, or the cardiovascular system. So there is a decreased cardiac output and stroke volume, particularly during increased activity or unusual demands due to increased rigidity and thickness of the heart valves, hence decreased filling or emptying abilities and decreases contractile strength. This may be accompanied by shortness of breath upon exertion and pooling of blood in the extremities. Reduced elasticity and increased rigidity of arteries is experienced by an older adult. It is due to increased calcium deposits in the muscular layer. There is an increase in diastolic and systolic blood pressure due to the inelasticity of systemic arteries and increased peripheral resistance. That's why sometimes if wala family history and then an older adult is hypertensive na. Orthostatic hypotension usually occurs in aging as a result of reduced sensitivity of the blood pressure regulating baroreceptors. So, in my patient, normal heart sounds can be heard upon auscultation, but are not as strong as a younger person. So, skin of the client is slightly cool, and in some parts it appears pale, especially sa kaniyang extremities. For the gastrointestinal system and aging, so my patient's stomach is very slightly protuberant, and it is soft, smooth, warm to touch, and his bowel sounds are up to 18 clicks per minute, which is kanang normal pa. So for the urinary system, the excretory function of the kidney diminishes with age, but usually not significantly below normal levels unless a disease process intervenes. So my patient has still a slightly complete control over his bladder and ability to go to the restroom to urinate. So napa siya control over his bladder. So psychosocial development. According to Erickson, the psychosocial development of late adults is centered on integrity versus despair. People who ego integrity view life with a sense of wholeness and derive satisfaction from past accomplishments. They view death as an acceptable completion of life. And according to Erickson, people who develop integrity accept one's one and only life cycle. By contrast, people in despair often believe that they have poor choices during life, and they could live life over. Wish they could live life over. So, according to my patient, he will come to accept whatever God plans to do or give to him. So, including the illness. He has come to realize that whatever you do in your life, for him, it won't be as meaningful as it is if you won't put God into it. So he has come to accept that. In his age, there is only one thing that will happen. So he verbalized that he is quite proud of what he has achieved and what he has done to mold their son into what he is now. So for the developmental task, Robert Havigers believed that learning is basic to life and that people continue to learn throughout life. He described growth and development as occurring during the 6 stages, each associated with 6 to 10 tasks to be learned. A developmental task is a task which arises at or about a certain period in the life of an individual, successful achievement which leads to his happiness and to success with later tasks, while failure leads to unhappiness in the individual, disapproval by society, and difficulty with later tasks. So, the development task during the age of my patient, which is 75 years old, adapting to safeguard physical and mental health, remaining in touch with family members, finding meaning to life, and adjusting to one's own body changes. Patient M claimed that he has long accepted his decreasing physical strength. For the cognitive development refers to the manner in which people learn to think. In older adults, changes in cognitive abilities are more often a difference in speed than in ability. Overall, the older adult contains intelligence, problem solving, judgment, creativity, and other well practiced cognitive skills. Most older adults do not experience cognitive impairments. Retrieval of information from long-term memory can be slower, especially if the information is not frequently used. They need more time for learning largely because of the problem of retrieving information. Cognitive impairment that interferes with social or occupational functions should always be regarded as abnormal. So, Mr. M, which is my patient, claims to have good memory but has already slight hearing changes. He's capable to recalling some information, but he has to be given time to do so. Mr. M's cognitive development is normal for his age, and although he forgets some information, it doesn't interfere with his social functions. So last would be the spiritual development. Older adults can contemplate new religious and philosophical views and try to understand ideas missed previously or interested differently. The older person also derives a sense of worth by sharing experiences or views. In contrast, the older adults who has not matured spiritually may feel impoverishment or despair as the drive for economic and professional success wanes. So Mr. M is very active in church. He goes to church either in the morning or in the afternoon every other day and goes to church every Sunday. He does novena prayer every 3 p.m. and 6 p.m. So review of system. So my case, acute gastroenteritis, it basically affects the gastrointestinal system. So short review lang. So ang atong GI system, it also of course it is for digestion of what we take. So it is divided into two: the upper GI and the lower GI. So the upper GI consists of the esophagus, the mouth, the stomach, until sa duodenum. While the lower GI system would be from the duodenum, including ang small intestines and the large intestine. And then short lang ang small intestine is for its function is to absorb products of digestion kanang mga carbohydrates, proteins, lipids, and the vitamins, while ang large intestine kay absorption of water siya. So let's proceed to my concept map. So start with the predisposing factors. Predisposing factors are age, which AGE, it usually occurs sa children, and then also malnutrition. And for the precipitating factors, like contaminated food and water. Like basically, acute gastroenteritis is an inflammation sa ato ang gastric system. Yes, the stomach and the skin because of course inflammation naturally foreign substance. So with the ingestion of contaminated food and water, it leads to so direct invasion of the bowel wall and also by the direct invasion of the bowel wall by the bacteria. And also as it can invade its endotoxins are released, so the endotoxins kay katong toxins nga release sa bacteria once they disintegrate. So some signs and symptoms if mag-release na kay katong mga flu-like symptoms like cough, headache, fever, then you can give some medical management and you can give antibiotics. With the ingestion of contaminated food and water, it leads to the stimulation and destruction of mucosal lining of the bowel wall, which then a sign of this is that there is a dental defecation or tenesmus and then after that it leads to digestive and absorptive digestive and absorptive abilities sa ato ang ato ang GI system will malfunction, leading to three things. First is getting there will be excessive gas formation. Symptoms of this would be GI distension, nausea and vomiting, cramping, abdominal pain. So, a nursing diagnosis for that is altered comfort, acute pain related to excessive gas formation. So, common management would that be provide comfort measures and apply cold or hot compress, cold if not indicated, then provide or administer pain medications if not, and then medicated pain. So after this one, it leads to increased peristalsis, and then with increased peristalsis, nursing management would be you assess the bowel sounds, and then as for my patients, bowel sounds are 18 beats per minute, so within normal range. And then so the digestive and absorptive capacity will malfunction, leading to the secretion also of fluid and electrolytes in the interstitial movement. So, which leads, getting increased peristalsis and secretion of fluid and electrolytes will lead to mild diarrhea or 2 to 3 stools a day. And then it then leads to fluid and electrolyte imbalances. So, fluid and electrolyte imbalances will lead to, as for my patient, it led to hypokalemia. And then with hypokalemia, because potassium has something to do with uh, the heart, mga muscles with high energy, high electrical activity, which is the heart. So my patient had hypokalemia, and then one manifestation with this would be pain, paroxysmal atrial fibrillation, which occurs on patient. So, from the heart niya, na-evidence of dili tarong iyang congestion. So, a nursing diagnosis would be fluid and electrolyte imbalance related to hypokalemia secondary to acute gastroenteritis. So, management would be monitor this intake and output, monitor the heart rate, kaya nang feeling hypokalemia, na regulation siya, then encourage intake of high potassium foods and increase in fluid intake. So his medications, medical management guide. In rule, which is an electrolyte, and then Claytonus as plus 60 mg of potassium chloride, which is a side drip, and then the IV na siya, D5LR. Then balik na isa to the electrolyte balance. So with this, it then leads to the large intestine being overwhelmed and is unable to reabsorb the lost fluids, leading to intense diarrhea, which is 10 times a day in a stool pass, stool defecation, and watery stool. This was manifested by my patient. He defecated at least more than 15 times before he was admitted. So, nursing diagnosis would be deficient fluid volume related to excessive losses through normal routes, frequent passage of loose watery stool, secondary to acute gastroenteritis. So, nursing management would be monitoring vital signs, monitor intake and output, and then emphasize an increase in fluid intake and monitor his IV fluids. Medical management of that would be rehydration with D5LR, the basic triggers. Replacement of losses. So, getting replacement of losses, nothing is on oral rehydration therapy. So, if less than 10 kilograms of body weight, this is getting siya kaya, contatical na siya kaya, wala siya kuan sa akong patient, wala siya kuan sa doctor. Wala siya oral hydration therapy. So, if less than 10 kilograms per body weight ang nawala sa iya, you give 60 to 120 cc of ORT for each episode of katong sa iyahang diarrhea. And then, if more than 10 kilograms of body weight ang nalusan niya, kay 120 to 140 cc of the ORT solution will be given. So, balik ka dito. So, an intense diarrhea could lead, if not managed, could lead to hypovolemic shock and gladly, ako patient ko na rin hindi natin. So, a nursing diagnosis of hypovolemic shock, which is basically is hypothetica, is altered tissue perfusion related to decrease in blood volume. So, nursing management would be have person-like flash with feet elevated about 12 inches, and then keep person warm and refrain from giving fluids by mouth, kaya basi ma-choke na siya. So, with hypovolemic shock, symptoms of this are cyanosis, decreased or no urine output, shallow breathing, confusion, rapid heart rate, and then weak pulse. So there is no definitive severe dehydration na din siya. There is no definitive medication for that, but pure rehydration. And then, the management of hypovolemic shock, it could lead to death. Let's go back to mild diarrhea. Diagnostic tests would dili naman ma-manifest na AGE. So, diagnostic tests of that would be stool exam of birth cultures and then blood exam. So, you can do the polymerase chain reaction assay, pero wala siya gibuhat sa akong patient. It is not done sa akong patient. This PCR it is a blood test na identify, it is very specific as to what bacteria then medical management, like oral rehydration therapy, and then azithromycin. But I tell you bacteria sa gastroenteritis are gram-negative, and usually they are resistant to quinolones, itong mga ciprofloxacin. Mga quinolones such as itong ciprofloxacin. So, Sorry. Malnutrition is precipitating factor. Why? Because malnutrition can be treated and also it can be prevented if adequate. There are several reasons for malnutrition, but low income, poverty, or it's something that you can alter and modify. Make it modulate your voice very. And then ang tenesus ko lang kailangan mo kalima. Focus ko kalima. You have the urgency. Like, if mag-diarrhea ka, magkikata na naka-acute with that, kasi masakit ng tayan, kalibang, because of fluid or fluid contamination. Kaya you have the urgency, but murag na kurot na tanan yung kalibang, and the feeling ng murag na pag-ana-ana yung muhang ilang finger, that's the response. Pero ba't na ako yung kalibang, buwan na yung kayo makaibang, kaya namurot na, pero you still have the urgency to defecate. That is why you will have voluntary movement sa iyong anal fingers. That's the response. Really good. So, it's the urgency of growth. Nakapil mo, Ana? Kaya napahurot na yung kalibang yan, yung mura pag iwang muscle sa anal area na straight na galing siya tayo, that's the shape. Kaya, same thing na if you have questions, you can go along. What do you say that your patient is just having mild diarrhea? What's your objective
data.
Objective data, ma'am. Measurement sa iyahang tools relate with ma'am.
Yeah, that should be one. Right, you have 2 to 3, what else?
And then, the first consistency puts us to, it's not an L, another ayo. Napashay ka ng gamay control over the.
How about the total body weight of the patient?
Body weight sa patient kay dili pa siya ma-decrease or ayo. Unlike sa severe diabetes, that's
And 5% of the total body weight required is lost, say, percentage. Whatever is the total body weight of your patient, if it's 5%, you consider that as mild diarrhea. If it's above 5% and below 8%, that is your severe diarrhea. You have always mentioned, even in your nursing care plan, diagnosis like fluid and electrolyte imbalances. How did we correct this one yesterday? Because Barbie was also identifying the same problem and stating the way you're stating it now. What was our comment? Or what was my comment yesterday?
This is by what electrolyte.
Yeah, you have to be specific. So you should have made the correction Alan, since we made it yesterday na. Like in your patient, it was very specific. What was the electrolyte imbalance that was undergone by your client? Based on the lab result. Hypokalemia. Your patient was having 3.0, right? Which is below the normal range that the medical center is actually using. Okay? This case would be within what category of hypokalemia? Because you have to know. You have mild, you have moderate, you have severe, because your management will be based on that one. Okay? What was the range that you were using for the potassium?
3.6.
To, which is also missing in your concept map. Because when you say there hypokalemia, why did you say hypokalemia? What was the lab result? Did you place it there? You cannot find your lab results in your concept map. That's the one that's missing now. Yesterday, Barbie was having that. What he missed was the nursing problems that she missed to place at the concept map as well as the management. Now, you're having that, but you're missing your lab values and your diagnostic exams and your significant physical assessment findings. Okay? Hypokalemia. What is the result of your patient? 3.0. Then you place the range so that your classmates will be refreshed nga, ma-ODI, na hypokalemia siya because ang iyang potassium is below the normal range. Kasi kung pag-yaw-yaw na ta, ako nakasabon ko. Pero ako ba yung classmates nakalimot naman na sa normal range, you have to refresh them, so you have to place it there. 3.6 was the normal that they are using. 3.6 to 5.0. That's the normal range that they are using. So, sa atong pa, your patient is having 3.0. So, what do you think is that? Mild, moderate, or severe?
Moderate.
It's moderate. Kung ang imuhang 3.6, no? Kung mababa na siya, like may 3.5 or 3.4, what do you think is the management for that?
Oral rehydration.
Like what?
Like increase the fluid intake and also potassium, like foods with high potassium.
Yes, definitely. Kung nag 3.4 to 3.5 na siya, because that's mild, you will not see replacement of your KCL yet. Hindi pa na-incorporate yung mga KCL. What you can see is, meron na siya dito, 2 bananas per meal. Meaning to say, pwede pang madala with oral replacement, especially with giving of foods that are rich in potassium. Okay? Aside from banana, what are other foods that are rich in potassium? Banana, what are the other foods that are rich in potassium? And banana, because in the Philippines it's set up, that's the most affordable and that's the one that we can see most of the time. When ang pirmi, una siya pirmi mahatag sa information, but other than bananas, there are a lot of sources of potassium. Like what? Banana, you need to have very good. What else? Your French fries has a lot of potassium because it's made of potatoes and your potatoes is very rich in potassium. So, mauwi daw na kung ay patient na renal failure, what's the contraindication is not to eat French fries and potato products because your potato is very rich in potassium. Your apple, your tomato, your cantaloupe, those are rich in potassium. Okay? Yan ang ano kung mayroon ka 2 cantaloupe per meal. Makuha ang patient binulong, gasa siyang bulong o cantaloupe. Okay? Hindi ka kayo tomato because not all patients have palatable taste sa mga tomatoes. Diba? Di ba talaga lang found tomatoes pero I'm sure almost all Filipinos would love to eat banana. Okay? And the fact that it's very affordable. Okay? Unang banana rin ang mula sa tulong. Okay? But you have other choices aside from banana. Now, your patient was having mild potassium imbalance. So what management do you see? Aside from oral replacement, like giving your patient banana, what else?
You was given Kalium Durul.
Yes, now you see there was Kalium Durul as a medication because there's a potassium replacement. What else?
Also, citric acid, potassium chloride.
Yes, you have your plain NSS mixed with your 60 mg of your potassium chloride. Okay? So, in that case, since your patient was having that one, what are your additional nursing considerations?
Always monitor ang iyang side dish kay basig mapaspasan ka, and then it is kanang vital pag i-monitor ang heart rate niya kay potassium has a vital function sa cardiac muscle.
And do you think the 60 mg of your KCL is within the dosage that is acceptable to be given to your patient?
For me, yes, okay.
Why? What's the maximum?
50 per hour. For maximum range.
Maximum for your potassium. Ngayon ka nga, after this, ang may mga physician nga, higher than yung aning nga range, bigyan na po administer ani. Okay, it's dangerous for the client. What's the dangerous dose of your potassium? Alright. Do you know that overdosage of your potassium can kill your patient? And do you know that that is one of the common substance that they are using to promote euthanasia and mercy killing? That's one common medication that they are using because if you overdosage ka ana, walay din maglalis. As what you said, the target is the conductive activity of the heart. Your client can go into cardiac arrest. I'm asking because kung lang daw version ay usual fluid, then it's not the usual fluid because you have an incorporation of your potassium. And it's very correct that you have to monitor the rate of flow. Because once kung pass na siya, and you do not regulate it properly, your patient can go to overdosage. Okay? Kailangan di ay ang maximum dose of your potassium chloride that you can give.
Can I get that question?
Yes, yeah. So you will search that one for us, give it to us. Na kung may ta, 60, okay ra ma'am, kaya huwag siya nilapaw sa maximum. Kailangan tayo ang maximum. Okay? Kung wala pa sa maximum, what will you do? Okay, let us say the doctor's order there says, plain NSS plus 120 mg of KCL to run for 8 hours. Are you going to administer it? That's the question. So that will be based on your answer later. Okay? what's the effect of hypokalemia? You know what? Ang immune representative condition is acute gastroenteritis with moderate dehydration. If that's what we are going to discuss, that would be very easy. Pero ang atong natawon now, what are the fluid and electrolyte imbalances that goes along with your moderate dehydration? Okay, yung fluid electrolyte imbalances, unang mas delikado sa inyong pasyente. What are the effects of your hypokalemia? What are the dangerous effects of your hypokalemia?
Heart, and then say muscles.
So what are those? What are those, Alex? Unang kuyaw. Remember, you said your patient was having 15 times bowel elimination before your client was admitted to the hospital. Wala na siya nadala, aside from fluid imbalance, which is very deficient, your client can really go to a very low potassium level. And if your patient was not managed at an early stage, your hypokalemia will have so many effects that are fatal for the patient. So what are the effects of your hypokalemia?
It can also lead to paralysis,
Paralytic delirious.
yes, then also, as I mentioned kanina, like as what you mentioned kanina sa mga cardia, it can affect the heart, fibrillation, atrial fibrillation, heart,
Kabalo na din kung isa ng pang-amazing. Third part of your fluid electrolyte lectures at level 3. Hypokalemia will have effects sa imong cardiac muscles, sa imong nervous system, sa imong smooth muscles, sa imong skeletal muscles. Okay? I would appreciate if you give the comments, you write it along sa inyong Manila paper. Para you can be reminded, you can be reminded also. Okay.